So to understand the treatments of chronic pain, you really have to sort of isolate your issues down into the nervous system, because chronic pain is almost always neuropathic. What neuropathic means is it's from damage to the nervous system. So if you have a bad hip or a bad knee, those are not nervous system issues. You can get those knees and hips replaced or injected, or sometimes even other treatments. But this talk will mainly be about neurologic pain. If you have questions about other kinds of pain, I'd be happy to do it. But when you look at neurologic pain, it's all about nerves. Nerves control the sense of feeling. So you can get numbness, you can get weakness, because nerves also control the muscle strengths. So those are within the gamut of neurologic and neuropathic pain problems. People get quite vivid about their descriptions, and it is important to us to understand the stabbing, shooting, burning, electric. In fact, when I'm trying to understand the character of pain, which is quite important, I'll spit out a bunch of different kinds of terms so that you can pick from one. Next slide, please. So we have people that are normal in everyday society. They can do everything, down to the people that can hardly move, and everything in between. So this is a chronic pain continuum you see on your screen right now, from being able to do tasks, play with children, be productive, into the things that make us happy, like crafts and arts and gardening and sports. And you'll hear us talk a lot when you come in about sleep. If you're not sleeping at night, you'll have a lot of problems. And unfortunately, in today's pharmacy companies, all the drugs we use for sleep need a rhythm, and those sleep aids will make your life better. And they're not the ones that you see on TV for ads. They're usually the older ones that are safer and more effective. So please bring up sleep when you come into a pain clinic of any sort, because it's imperative you get that monitored and fixed. Next slide, please. So most people who come to us have already tried ibuprofens, have tried Tylenol, and all the medications that used to be used, such as opioids, are more back burner. A lot of patients don't want them anymore. And a lot of physicians refuse to treat with opioids. There is a happy medium, and some opioid use is important, especially post-operative pain, like after a stimulator or after a surgery we do. Those kind of things are imperative and important to regulate your body systems. Physical therapy is something that insurance is really insisting upon. So a lot of patients have already done physical therapy by the time they come to see a pain specialist like me. But it can get in the way if you haven't done it yet, because insurances are saying you need to do so much PT before we can order film. So if you can do that before you come, that'd be great. It gets things out of the way so we can get to the next step, which you need, or you wouldn't need a person like us. We can talk about drug pumps. It's not part of our treatment algorithm that we have on the schedule tonight. We can talk about surgeries or nerve blocks. Most of what we do in a pain facility is nerve blocks, because people need them so much. Again, it's not a focus tonight, but feel free to ask questions about it during the Q&A. Next slide. So the big three topics tonight are radiofrequency ablation, spinal cord stimulation, and a procedure called Vertiflex. On the screen, you see it as indirect decompression, and we'll talk about why during that part of the lecture. But indirect decompression is using a spacer to be able to space apart your vertebrae. And it's the newer treatment that a lot of people have questions about, and hopefully you'll understand all about it after tonight's lecture. Next slide. So radiofrequency ablation has been around since I was young, and it has really improved in the past few years. There's newer versions of radiofrequency ablation. Most of them are targeting lumbar spine arthritis. If I could dismiss the issue that people usually have, they'll come in and they'll say things like, oh, it's just arthritis. So there's not much you can do about it, which is exactly wrong. There's a lot you do about spinal arthritis. Almost all of it is radiofrequency ablation. You take a needle that has an insulated shaft and a bare tip, put it down where the nerve supply goes into that arthritis, zap the nerves to kill them off so that you can get extended pain relief. Most radiofrequencies that are done through needle probes. We do have a more advanced one now that's endoscopic, you know, big screen TVs, cameras going down in to do these burns more proficiently. But radiofrequency is the standard of care for spinal arthritis. And if you think your back hurts just a little, it's probably not because of spinal arthritis. Spinal arthritis hurts a lot. The more severe it is, people would assume that you can correlate that severity on x-ray and severity on all kinds of images, but you can't. You have to test it. You have to put a numbing shot down into these nerves that go into the joints, see how they feel for 3 hours afterwards. And if you feel great for those 3 hours, we know it's spinal arthritis and not your discs, not your spinal nerves, but that's the standard of care. The standard of care means we do what we have to do to be able to diagnose this. Next slide, please. So that was a quick and dirty on radiofrequency ablation. It makes you sore afterwards, but it is a wonderful treatment. It really changes lives, and a lot of people benefit from it. Now we're going to get into spinal cord stimulation, which is one of the big things that Boston Scientific makes for us. You can see their batteries and remote controls up there. The batteries you see, the Alpha WaveWriter battery, has 4 different versions, and that's why there's 4 different batteries there. The ones on the left are important to realize that those have all the charge, all the juice of a battery in them. You don't have to recharge them. The ones on the right seem smaller, they're rechargeable. You have to recharge these at set intervals, like once every 3 weeks, you have to wear a belt that sends the energy into the battery. These are important distinctions so that if you get offered a choice, you'll understand all about it. But I can tell you that I've done this a long time, and I've used rechargeable and non-rechargeable batteries in the past. And most of the time, the stimulation waveform, the electronic specifics of the stimulation that we use will make its decision for you. Meaning we need to make sure that that battery doesn't need to be changed within a certain time frame. So if you can get a battery with all the electricity already in it, that's great. But if you need the WaveWriter Alpha that's rechargeable, we'll decide that for you and explain it all to you before we do an operation. Next slide, please. So another issue that, before we get to this one, is, and go back one slide, please, Elizabeth. Down in the right-hand corner, it says image-ready MRI. MRI safety, really, I would consider it to be a standard now. Just a few years ago, MRIs couldn't be done on stimulator patients. Now it's routine that we can do them on patients with these batteries in them, and with almost all of the spinal stimulator leads that I run into with Boston Scientific. So it's important to understand you can get MRIs now where you couldn't in the past. If you're a patient that has a stimulator already and you would like to get MRIs in the future, ask your doctor. It just takes a phone call for us to figure out whether we can convert you to MRI safety. And most of the time it's just swap out the battery. taking out a battery and putting a new one in. You just open up the previous incision, take out the old one, plug in the new one, sew it shut. So it's a fairly isolated surgery that takes 15 minutes and gets you able to get better clarity. MRIs are really so much better than CAT scans that it's important to understand that you could be MRI safe, most likely. An interesting thing about the newest innovations by Boston Scientific is in the middle right, where it says fast contour programming. And this really changed everything that we've done in the past, I'd say a year, 2 years, because patients that have previously failed spinal cord stimulation trials are now able to get this new type of waveform programming that allows you to be able to get another trial and be able to get a stimulator, because it would be successful a lot more often than it used to be. So for people that are watching this that did a trial and it failed before, I've had quite a few patients that we've retrialed with the newer technology that you see on the screen there, and passed the trial and went on into permanent implant. In fact, I had about 7 people that I wanted to be able to try this on because they had failed a previous trial and were just waiting for technology to help them. And so we called those 7 people, did trials, and all but one passed the trial when they previously failed it. So the technology now to get pain relief is very significantly different than it used to be even a year and a half ago. All right. Is this a good place to stop, Elizabeth, to answer any questions? I saw a few things crossing the screen, or would you like me to keep going on?
We did have a question about radio frequency ablation come through. If you want to talk about that. There was a question that says, what's the downside of RFA, and how long does the procedure take, and how often does it need to be repeated?
So there's not a lot of downside to RFA, except that you're sore for a couple days. The procedure itself is not a dangerous procedure. We do them, I probably did 3 today. Out of 20 patients, I did 3. And patients generally feel like it's very similar to the trial injections that they have. So it's a similar procedure, same locations that they get injected. The only difference is you put a micro wire down into the needle to conduct the current. All of our pain doctors use local anesthetics down before they create the burn, so you can't even feel the burn happening. In fact, many times if patients stay awake for it, we'll be talking about things and I'll say, do you feel anything right now? And they don't feel it. The burn happens within 60 seconds, and then it depends on how many burns you need for the kind of arthritis locations that you have. And then you're back out into the recovery area. It feels like probably 15 minutes to do all of it. So you have the pre-op and post-op. Altogether, we book them for 40-minute appointments, and we have more than enough time. So it's not a lengthy procedure. It's a little longer than a regular injection, but not much. And you might get sore over a day or 2, but it's still more like a bad back day or a bad neck day. Incidentally, you can have a radiofrequency ablation in the cervical, thoracic, and lumbar spine, and it's similar in all 3 locations. I hope that answered your question. If it doesn't, please send through another one about specifics. But you'd consider it almost a fancy injection and not really a surgery at all. It's just an injection. If you go on to the other kind of radiofrequency that I talked about earlier that has a camera scope, that it can be more painful. You can be sore up to a week after that, and that you might need pain pills for afterwards. But again, the relative risks of these procedures are extremely low. We have maybe one patient, I have maybe one patient a year with a radiofrequency ablation that will complain of pain that comes down, say down the neck to the shoulder. And that usually goes away within a week, but that's one out of an entire year.
Dr. Bojrab, just two follow-up questions. One is asking how long should the radiofrequency last?
A standard radiofrequency's duration is all about how old you are. So if you're 30 years old, you reheal your tissues, so it heals up that burn and brings back normal nervous system supply within a half a year, 6 months. If you're 40 years old, you'll get about 7 months, 8 months. If you're 50 years old, you get about 9 to 10 months. If you're over 65, it's more like a year to a year and a quarter. And then you can reburn them at set intervals. Insurance generally pays for them twice a year, so every 6 months. But most patients that come to our clinic are in their 65-year-old range, and they get them about once a year.
Thank you.
No problem.
They're a previous patient of MPS.
They were last there in March. They had injections that didn't help much, and they suggested either stimulation or Vertiflex. He's been seeing a chiropractor who said if he got anything inserted, I needed to see him. He said he wouldn't be able to help me. Still have chronic pain as when I see Dr. Washabaugh. Would it behoove me to come back to MPS and see Dr. B for any new procedures?
Well, all three of our doctors do all of these procedures. So if you saw Dr. Washabaugh and you come in and talk to him, he'll probably give you a whole host of new things that you could do. If we're going to talk, we'll get a little into that here in a little bit once we get to the Vertiflex talk. But if you like to go to a chiropractor and you have benefit from it, I always tell people they can't go for the first week after a Vertiflex, but after that, there's no issue at all. You can have chiropractic adjustments as much as you need after the first week of a Vertiflex. It does not limit them from being adjusted. So, did that answer the question, Brooke, you think?
I think so. Thank you, Dr. B.
Thank you. All right, let's keep going with this discussion about spinal cord stimulation. It's of course FDA approved. It's been FDA approved since way before my career. I think the first stimulators came out in the 70s, and every, I'd say maybe 3 to 5 years, we get some latest and greatest fantastical thing that they improve on. And it's something that just keeps happening to improve. And it makes sense because it's a computer thing, and computers just keep getting more advanced. There's no drugs going through these systems. They're completely electrical. What we work on and what they improve the technology with is the improvement in computer designs and electricity. I'm sorry about these beepings. Stimulation is covered by almost every insurance. I haven't had but maybe a couple that were rejected, and it hasn't been recently. And the real reason is the success rates in medical journal articles is so important, and there is so much positive journal articles written on the subject. So it would be hard for an insurance company not to say it's less than medically necessary. It's obviously medically necessary in the vast majority of people that present with neurologic damage. There is recently something that insurances are requiring, especially Blue Cross of Michigan, and that is that you go see a surgeon and they have to agree to be able to get a stimulator. So if you get that kind of discussion out of one of us, your pain doctor, it's one of those things that we're jumping through the insurance hoops to be able to get you what you need. There are obviously complications. It's a surgery to put in a stimulator. So it's one of those things that I think in the future slides, hopefully, we'll be able to discuss it. Next slide, please. So a lot of us equate the leads on a spinal cord stimulator to a spaghetti noodle. Because they're sort of flimsy, there's a little micro wire that goes down inside the lead that we can stiffen them up just for the purpose of putting them in, because otherwise they're too flimsy. So once we decide to put a stimulator trial in a person, we put a needle that's very similar to a labor and delivery epidural needle, and we put it down into the spinal column epidural space and put the lead through it with its stiffening wire and drive it to where you need it. Once we're done with that, we take out the stiffening wire and we take out the needle, and all that's left there is this little spaghetti noodle lead, and it looks like a whip that has little electronic tips on it, and that's what conducts all the electricity. So this isn't very invasive. It is very soft and very pliable, and if you talk to people that have had prior surgical implants of stimulators, some of them were done in the past with paddles that can't be moved very easily. And that's not what we're talking about in today's lecture and today's technology. Nowadays, we have these little leads that are very soft, very pliable, and they can be adjusted in location in the future. So it makes it easier to be able to move them. The battery is not just a battery. The battery is the brains of the operation. It has the computer microchips. It has the MRI shielding. It has the connectors that you see on the top, the more clear connectors that we put the lead in, and that's the connection between the two.
Dr. B, I have video links that I'm going to send out afterwards, unless you want me to play this right now, but if otherwise, I can have it sent to everyone after the webinar.
That sounds better if you send it afterwards, because it'll give people more question and answer time.
Okay, sounds good. I'm going to go to the next slide then.
Please. So I like to tell you about what the process is like. In fact, many years ago, I went to Boston Scientific and all the manufacturers of stimulators, and I said, you know, we don't need to talk about what a stimulator does. We need to tell people in the brochures that we give them, we need them to understand what they're going to go through. And that's a big deal, because this is a real black box for people that are patients. They don't know what they're getting into. Then they have to understand it's a two-stage process. This isn't one procedure, it's really two. And they have to understand their expectations, because with a stimulator, we're not making their disc better. We're not making their ligaments better. We're changing how they feel pain. And that's a big deal. It changes how you feel pain. And I like to tell patients, it's like you put a jamming signal in there. And by jamming it in certain ways, it makes you not able to get that pain up to your brain, and therefore you don't feel it. You don't sense it with your brain. So I tell people generally this is a 75% improvement as a standard. You see down at the bottom of the screen there on the left-hand side, a 50% improvement, at least at rest. This is mainly trying to say that this is what we'd like to be able to consider this a success. But I'd say the average pain relief that people should expect, not knowing before they get into it, is you should expect around 75% improvement. That if it's less, okay. If it's more, that would be great, but it's 75% improvement is what I generally get and what pain doctors get when they do these procedures. So it's a huge issue to be able to know what to expect. If you have a trial done and nowadays, or maybe you had one done many years ago, we used to do 3 day trials. Now we do 7-day trials. And the reason isn't because it takes longer to figure it out. It's because we have so many optional programs that we need to try out on you that we never had before. And instead of 3 days, you have all these different things you need to try. It took more days. So if you talk to people, I know patients like to talk to other patients and get the ideas from other people of what they went through. But that's why we have these brochures we give you. That's why we focus on the DVD at the end of the packet. That's why we get you with patient ambassadors or reps to be able to talk to you about their technology, and of course, us doctors to be able to tell you what you feel. So if you pass the trial and you want to go on to a permanent one, that's a personal choice that we make with you, but the patient is really in control of that. Then once you get past that 7-day trial, we take the lead out, you're back to normal. You tell us if it worked and if you want the permanent one. And really it makes its own decision. If it works good for you, you'll want the permanent. If it doesn't, you won't. A big question that people ask every time is, will I not need pain medications? Will I not need injectable procedures? And it's hard to answer those kind of things because it doesn't keep you from those things. But most people don't feel like they need those sort of things. Most people naturally will go off their pain pills because really they forget to take them because they're feeling pretty good and they're doing things when they have a stimulator in. So similarly, they increase their activities. They can sleep more because it doesn't hurt so darn bad. And it's a big change. And you'll see that on the videos that I'm sure she's going to text you these videos too. But improving your sleep, improving your function, having more fun, getting pain relief is all part of this. It's not just pain relief.
Dr. Bojrab, we had a couple questions come through, if now is a good time.
Sure, go ahead.
One, not to go back to radio frequency, but I didn't want to miss the question, was they just wanted to ask if it's protocol to have an MRI before getting the radio frequency.
Back up on the question mentally. When you come in and you see a doctor, we like to figure out what's wrong. And by most of the time that includes an MRI nowadays if it's spine pain. Now, having said that, if you already have an x-ray and it shows a rip roaring arthritis and you want to do that before you go on to look in deeper at the MRI, I've done that many times. It's fine to do it that way. And it's up to you and your doc how you handle that. But you don't have to have an MRI ahead of time. It's nice to define the problems, but you don't have to.
I think that also relates to spinal cord stimulation. Would you agree, Dr. Bojrab?
I would want an MRI as a physician with something like a spinal cord stimulator because, there are things that are odd, that are strange, like arachnoiditis or spinal infections or all these different things. You really need an MRI. It's not as easy as an arthritis, so you would need an MRI ahead of time.
Okay, and then 2 more questions related to spinal cord stimulation. Would you like them now?
Yeah, go ahead. Okay,
one is just, is there any activity that you cannot do if you have a spinal cord stimulator implanted?
That's a good question. Within the first 2 months after you get a permanent implant, the surgery part, you can't twist your trunk. And the only way I can do this well is go like this with my trunk. We don't want you doing that for 2 months. And the reason is the leads settle in and they get these little micro scars. And think of my fingers right here sitting on the back of a circular spinal cord. And if one of them goes like this, that's not so good. That means surgically we got to go in and fix it. And so you don't want to twist your trunk within the first 2 months, because after 2 months, the likelihood of that is slim and none to have that kind of problem. So it's better to wait for 2 months. Now, having said that, let's talk about the time after 2 months. It would probably be not such a great idea to be bungee jumping or rock climbing or something where you can have an enormous jarring of your whole system. Something else that if you're not a good horseback rider and you try to trot, that would be really pushing it. But most people don't run into those kind of things. And for the most part, you can almost do anything short of those enormous forces on your body. You can swim, do all kinds of stuff, hiking, whatever you like, short of big jarring things.
Thank you. Before moving on, just one last one. It kind of takes us back to radio frequency. It just says, I have a herniated disc at C7. You seem to indicate RFA is for those with spinal arthritis. Would RFA still be good, or is a fusion the better bet?
You have to separate it and say, if I have a herniated disc, do I also have spinal arthritis of the joints next to it? So the radiofrequency ablation would be for the spinal arthritis, and it won't help a herniated disc. The disc is separate. For a herniated disc, a discectomy is better. You said cervical, so discectomy and fusion is what is the standard of care after epidurals are done. So again, they're two separate issues. To separate those out, what you need is do the medial branch block nerve blocks and see how you feel for the first 3 hours. If you feel great while the numbing is on the joints, then radiofrequency is a better idea. If you don't get any relief for those first 3 hours after the injectable local anesthetics, then you need to address the spinal disc and not do a radiofrequency ablation.
Thank you.
So let me get back to the previous question that you had there for a second. It is quite common that patients will do things actively with stimulators. They're not limited really, and they fall once in a while, and maybe I'd say once every 2 weeks we get phone calls that a person fell and they hit their spinal stimulator on the concrete or whatever they were doing, and it's these systems are very strong. I wouldn't say indestructible, but it is extremely rare to have problems with a device impact on the battery. And so we usually tell patients to call us, talk to the reps, turn the device on, see if it stimulates you in the correct location. And 99% of the time, it doesn't hurt it. So it's one of those things that it's nice to know how strong and problem-free it is during impacts. Next, please. Brooke, did you have another question?
No more questions at this point.
Okay, please go back to the previous slide because I meant next question, not next slide. So let's cover the previous slides issues.
I'm trying, Dr. B, sorry.
I'm sorry about that. I said the wrong thing. Okay, so what I talked about a little while ago was the fact that we went from 3-day trials to 7-day trials in the past few years. And it's because of what you see on the right side of the screen there. When you see the word paresthesia, that means like a tingling or nerve sensation, a numbness, a vibrating. These are all descriptions of what a paresthesia is. And a paresthesia to us means a nerve function is changed. And you get those feelings in an arm, leg, or even in your back or neck. And so the stimulators put electricity through them. And so we call that paresthesia too. So some people feel it as a vibrating or tingling, and but what was created a few years back was paresthesia free, and we call them silent programs. Silent programs, you don't feel anything. You're running your stimulator and you don't feel a thing. And that's one of these new programs that got a lot of people better that we couldn't get with just the paresthesia based programs. And then they created a Wave Rider, which was the first battery to be able to do both of them at the same time. And then now they have a new system that even has further programming that we never had before. And again, One negative to all this is that it uses a lot of energy. So you might have to recharge your battery a little more often, but it is well worth it. Next slide, please. So if you look at this slide, you're just saying, well, how good did people do? How much pain relief on pain scores did they do? And going from an 8.6 down to 2.98 is a big change. Most people will tell us 70, 75%, as in their words. And these pain scores are done by research on asking everybody pain scores, but it's roughly the same thing. Next slide, please. Patient ambassadors. I think you're going to hear from our patient ambassador that's part of our lecture tonight. And it's important, probably the biggest focus we have with these webinars and in-person lectures is patients being able to ask somebody that has a stimulator in. And they've had these questions thrown at them many times. One thing I would caution people about is, and they're going to do it anyway, is they ask family and friends that have a stimulator in. Because a lot of times that other person doesn't have a stimulator for the same reason or the same nerve damage, or but again, our patient ambassadors have a breadth of knowledge of more than just their case. So I think we'll have Chris take it away here.
Sure. Can you hear me, Dr. B?
I can.
Okay, great.
Thanks for being part of it tonight. It's a big deal for our patients.
Absolutely. Thank you for having me. I appreciate that opportunity. So yeah, I mean, that's kind of what I was thinking is like, what's important, what was important to me going through this journey and really sitting down and thinking about that. I think it was this, just being able to hear from somebody else and ask those questions. And, so what an honor it is to be here with you guys. And I really do appreciate that opportunity. My name is Chris Booth, and I'll share a little of my background. I've worked in healthcare for about 25 years now. I've been a nurse for 15 years, and I share that with you because that's kind of how my journey started. I got up real early one morning, headed to the hospital to work in surgery, and a gentleman had been driving an 18-wheeler all night on the interstate and actually fell asleep driving and just kind of, played monster truck with my car, I guess. And I was just about all that was left of my car. And ironically, I'm headed to the hospital to try to help someone and went to a completely different hospital to be the one that needed some help that day. And, I think that's just how quick life can change sometimes, just in an instant. And I'm sure some of you guys can relate to that. But I spent quite a while in the hospital, underwent several procedures trying to kind of piece me back together. I kind of felt like the Scarecrow in the Wizard of Oz, just getting put back together, I guess. And went from the hospital to my house, and went from bed rest to a wheelchair to a walker. Walked on a cane. Actually, I still have my cane over here. I keep it over here in my room. I kind of call it my thinking stick now. I walk around with it and think, but kind of remember all that time. But walked on the cane for about 2.5 years. So my pain is mostly in my lower back and wraps around to my groin and then runs down my leg. And, the doctors are always asking me, well, what's your pain level? If 0's none and 10's the worst you can imagine, what is your pain? And mine stayed at about a 7, 8, 9, just a high level of pain that it's hard to focus or be a part of anything going on around you. I was just a young guy trying to provide for his family. I'd only been married for a couple of years at that point, and our daughter, for the ones watching, that's my daughter on the screen up there. She had just turned a year old, and it was tough for a dad to not be able to pick your baby up and hold your baby. And You know, I can remember my wife and our little girl leaving in the morning and watching the door close behind them and just, you know, laying there all day waiting for the door to open back up. So a tough time, kind of a dark time, trying to go through all that and deal with it. But after all the surgeries, it was, what do we do about the pain? You know, and I got involved with pain management, and I mean, we tried everything, all these different treatments with the physical therapy and the water therapy. And, you know, at one point, I think I was taking 16 different medicines, you know, not all pain medicine, but the muscle relaxers and kind of just all the things that go with it. And we tried TENS unit and did the injections, did several rounds of the injections. And I actually want to say that they helped a little bit, but for me, they didn't last very long. And so at some point, my doctor came to me and said, you know, Chris, I don't know if you've heard of this company, Boston Scientific, but they actually make a device for your type of pain if it's something you're interested in. And I said, absolutely not. I don't want anything. I said, I've already had all these things done to me and all these procedures. I don't want anything else done. And I kind of ran from it. I went back to physical therapy for probably another 6 months or so. And it was really more at a follow-up visit. And they said, you know, Chris, this is still an option for you on the table if it's something you want to look at. And I think me personally, I was just in a better place to be more receptive to kind of hear them out, hear what they had to say about it. And I read the material and watched the little DVD and asked a whole bunch of questions and went home and talked to my wife and my family about it, did some praying about it. And the answer I came up with is I wanted to see about this trial that we were talking about tonight. Because I looked at it like, if the trial helps me, I might can move forward with this. If it doesn't, I'm just kind of checking it off a pretty long list of things I've already tried that hadn't worked for me. So I really didn't know how much faith to put in it, but I thought, you know, if it doesn't work, I'm really no worse off than I am right now. So kind of, what have I got to lose? I might as well try it. So I did decide to go forward with the trial. And guys, I can't tell you how awesome my trial experience was. I mean, it was unbelievable. It was kind of night and day. That 7, 8, 9 pain that I described, it during the trial, it went down to about a 1, 2, 3. You know, just really not a 0, but it brought it back into a level where I felt like I could appreciate what was happening around me. I could be a part of the world again. I saw that I was able to do a little more. My activity level increased. But also a big thing for me is I had such a hard time sleeping. You know, I would go to sleep and I'd wake up with these spasms and cramps and all running down my leg. But during the trial, I found that I could even get a good night's sleep with the stimulator. So it was, I mean, just an amazing experience for me. But finished up the trial, went back to the doctor's office and finished up the trial. And they said, you know, Chris, is this something you want all the time? Do you want to feel this relief all the time? And I said, are you kidding? I don't even want to stop the trial. This is great. I want to keep this going. And, you know, that I decided to move forward with the next steps of it to having this all the time. And that's now been a little over 8 years ago. I've had my stimulator for 8 years. I still use it every day. It still helps me every day. And, you know, I never tell anybody, oh, you need to get a stimulator because I've got a stimulator. I just think I'm a good example of what it can do for somebody. So that's the best advice I can offer people when they're asking about it is, you know, maybe don't be as stubborn as I was. Ask your questions. Listen to what they're trying to tell you if they think it might help you. Because if it does, it really could change your life. You know? So that's my story. That's my journey kind of to where I am now with it. But I really appreciate that opportunity to be able to share it with you guys this evening.
I bet we have some Q&A for Chris.
That's
Sure,
what I was
absolutely.
just going to say. If anybody has any questions for Chris and his experience, please, you can send them through the chat, and I'm sure he'd be happy to to answer anything that you have, or if they come up as we go, we can always circle back too, if that's okay, Chris.
Chris, I have a question for you. Did you get the newer battery? The latest and greatest alpha, is that what you have in, or do you have the previous generation?
I look forward to getting that new latest and greatest alpha. And I think that's kind of neat because it really just kind of speaks to the longevity of it, I guess. Mine is more than 8 years old now, and I still get good relief from it. But I do look at some of that you were talking about with the alpha, and I say, man, my goodness, these things are so awesome. It's almost like it's going to start your car for you or something with the next generation. So I do look forward to that time when it comes.
Well, we have a trouble with, patients that have had other stimulator brands, or maybe we're looking at how we're trying to make their case better with predicting if alpha will make it different. So every case is its own case, and it's hard. That's why I was curious which model you had.
Yes, sir.
Dr. Bojrab, we did actually have a question come through for you in the chat feature. Just wanted to ask you. It says, I had my second injection today, steroid, and have up and downs on my pain levels from 2 to 8, mostly 2 to 5. Second injection was 4 months after my first. How many injections lie ahead before I should look at spinal cord stimulation trial?
Well, there's not a set quantity to give you a straight answer on that. It really depends more on what's going on the MRI and x-rays that you've had and which disease state's causing you pain to be able to say, okay, we've adequately injected it to see what our answers will be. And there's so many of them, it's hard to give you a number. But there's a feeling a doctor gets that does this on whether they think that you're going to do well with a stimulator. So, if I see a person and maybe they're a little bit more painfully, like burning pain or those different clues that they give us during the discussion, and you'll hear people like me throwing out the idea of a stimulator. If they're throwing out the idea to you, it's probably a good answer that you'll do well with it, because those are the kind of things we predict. That's the things we look for to be able to counsel people that this is a good pathway for them to go through. Sorry, I couldn't give you a straight answer, but that's as close as I can get.
Thank you.
B. Oh,
Yeah.
sorry. We had
Go ahead,
another
Elizabeth.
question come. Okay, sorry. We had another question come in too. Somebody said they've had problems with anesthesia and wants to know how long is a patient put under for the spinal cord stimulator, both for the trial and the permanent one? That's
a great question. First time I've had that question ever in the webinars that we've done. The anesthetic of choice that we use for stimulators here at Michigan Pain are really propofol anesthetics, because we want you to wake up quickly. There's very, very few people that have trouble with propofol only. So I would say that it's probably negligible that you would have problem with the trial. Now, the permanent is a different anesthetic, and it's a mixture of different drugs that make a good anesthetic. So it's best that you talk to one of us and bring up the issue. Let me tell you about it. Bring up issues like genetic diseases of anesthesia and counsel you on the issue. And there's ways to work around almost every one of them. Some take longer, so it could make the procedure or surgery longer. But we get around it and get it done just fine. But these have to really be tailored to each person's needs. All three of us are anesthesiologists in our primary degrees, so this is an easy one to talk people through.
Dr. B, earlier you were talking about the options with programs that you can feel and programs that you don't feel. And I was wondering if Chris could talk a little bit about the programming preferences that he has.
Yeah.
Sure, that's a great question. People are always wondering about that. So I like that you have options, that I feel like it was really made for me, it's made for my pain and the things that I experience with it. There are times when I'm more active, sometimes that I want to feel some tingling, almost like a kind of a pleasant massage that feels good to me. But then, like I mentioned earlier, I use it even while I sleep. And I find that tingling kind of keeps me awake a little. So I'll switch it to one maybe that I don't feel, and I'm able to use it even while I sleep on the no feel, and I wake up even feeling better with that. So I kind of use a little mixture of both, probably more no feel than feel, but I like that those options are there for me.
So I have a idea that, Brooke, are you on the line still? Can you get so we can hear you?
I'm right here, Dr. B.
Okay, so why don't you tell everybody how often you can that you use a silent program versus a paresthesia-based program, and sort of break it up into percentages for people.
Yeah, I wish I had the perfect answer for that, to be honest, but even the literature shows that there's not a one size fits all. So most patients either go between one of the silent or one of the tingling programs. I will tell you, during the trial, we traditionally start on tingling for the first day or two to see if you like it, because the tingling is actually a good diagnostic tool for us to make sure that we have the right nerves collected. And of the people who, during the trial, in our territory at least, about 65% of all patients who move forward with an implant, they still have some tingling running from what they chose from their trial. But that's not to say that's what they're using for the lifespan of their equipment. Patients who have implants in for 3, 5, 6 years are switching. Sometimes they prefer silent at night, and sometimes they like tingling in the day, or vice versa, depending on their activity.
That brings up a good thing that I would like to know if I were going into a stimulator. Do they use the silent more at night? I mean, or do people use paresthesias during the sleep?
Yeah, that would definitely be something good to track and research. I don't know the exact answer for that, though, but we do see people switching back and forth in the evening.
Okay, thank you.
Of course. There was one more question. Someone asked, how many stimulators have you placed yourself, Dr. Bojrab?
Oh, gosh. I don't know, honestly, throughout a career of them. I would say thousands, but I don't know how many. I mean, I can talk about my experiences with them and all that sort of thing. And I'm a researcher for more than one stimulator company, and I just have lots of experience with it. I don't know what else to say, honestly, but I'm old hat at it. I've done it forever.
Thank you.
Thanks.
Thank you, Chris, for sharing your story with everyone tonight. We really appreciate you being here. I don't know if you're able to stay on or not, but if we have other questions, it definitely can hopefully connect patients with you if anything comes up after the fact.
You are so very welcome, and thank you again for the opportunity. I'll try to stay on the line just in case there are other questions, but I'll turn my camera off just so I can pay attention and listen as well.
All right, thanks so much.
Thank you.
Thanks, Chris. All right, we're going to switch topics to Vertiflex. And Vertiflex is what is called an indirect decompression system. And you can see it right there. It's got the purple wings, and it goes between the spinous process bones. So the bone that looks like a fin above it and below it, we have to wedge this little thing in between those fins. A good question, if I were trying to analyze this as a patient, would be, what's in there already? Because all we see on this picture is a skeleton, and it's very loose connective tissue in a living human in there, and there's not anything that's important, certainly not nerves at all in that location. So that's what makes this an ideal location for an implant if it would help. So what the theory of this is when you sit, these bones vertically squeeze together. I'm sorry, spread apart. And when you stand and walk, they squeeze together. So this little implant is like a block you put in there, and it won't let them squeeze together from top to bottom. It tricks your back into thinking you're actually still sitting when you're standing and walking. And that's really the bottom line of this. It tricks your back into thinking you're still sitting when you're standing and walking. So the big question for us to as a screening question, after we see a little stenosis or a lot of stenosis on MRI is, when you sit, do you get pain relief by sitting? And if they say yeah, then boy, this is first in the thoughts, because it is a tiny procedure. We make an incision about maybe a centimeter high, and wiggle this little thing into an exact location under X-ray guidance. I mean, almost all the time is making the implant location just perfect before pulling the trigger and having the little purple wings go up and down from the central location. So it's all getting it in the perfect spot to make it work for you. And it's about 15 minutes of surgery to put one of these in, and 30 minutes for two of them to be put in. But again, the trick here that we're taking advantage of is to put a little implant in that makes your pain the same all the time as you get when you're sitting. So for patients that say, oh, I still hurt when I sit, this is not the procedure for you. The procedure is really for people that can sit and feel good sitting. In fact, a lot of patients will joke with me and say, if I could just sit all day, I'd be fine. And it really is true. As soon as they make comments like that, you think Vertiflex. And Vertiflex hasn't been around that long. There's a 5-year trial research study that was done before they even launched this product. So 5 years is forever in medical literature. And so it really was tested before they put it on the market. And once they did put it on the market, they're very selective about who gets to put them in as physicians. So all of us are well trained. It has been a good process. And when you look at the screen here, it sort of shows you people that have these issues. The people on the right there are sitting, and the green is supposed to mean that their spine is good and they're happy and it doesn't hurt. Or when they lean on a grocery cart, it sort of leans them forward and spraces out the bones in their back, and they love that grocery cart. And when they're standing and walking, it hurts. And those are the people that do well with a Vertiflex. So a lot of people say when they're sitting, if they stand up from that sitting position, they get a bit of a surge of pain. And that's a nice little thing. It's not critical, but it's one of those things that very commonly happens to be in the patient's story when they come in. You can see towards the bottom there that, their sciatic nerve got so bad and it helped them, or they can't live without a grocery cart if they're going to the store, or these incidental things. But if I could impress upon people the big issue here of this part of the lecture, it's if you get relief by sitting, this is something you really need to consider. Next slide, please. Okay, so if you look at the bottom pictures of vertebra, and it says stenosis right there where her pointer is, then you see those red lines in there. That's when things are too tight, and they're putting it in red to sort of catch your eye. And those are the nerves inside your spinal canal, and the ones trying to escape on each side, those are severely pinched. If you go to the healthy spine on the left, to your eye, you might say, oh, the yellow nerves look similar. But when we look at them on MRI, it's much more drastic than this. These aren't the greatest pictures for you to see and understand. But again, when you lean forward, generally you get pain relief. When you sit, you get pain relief. When you stand and walk upright, it hurts. And that's what lumbar spinal stenosis is. There's not enough room for your nerves. And when you look at an MRI, which of course your doctor will go through with you if you're a candidate for this, they'll show you why we're doing it and why they're recommending it. Is when you look at that MRI and it's too darn tight, and you give them that piece of important history. But when I sit, I'm almost all the way better. That's when things line up and you become a candidate for Vertiflex. Our doctors, I don't know how many people on this call are from other practices or other parts of the state or country, but our practice, we do research on these topics. So again, this is a high-tech talk about things that are new and innovative and electronic and spacer devices. And these are kind of things that will come up in your conversation with our doctors. If you haven't seen them for a while, it's something that if this appeals to you and your story sounds like this, you really should just get an office visit to go over the new technologies with them.
Dr. B, we do have one question that just came through the chat. They were asking, can you implant Vertiflex in more than one area?
Yeah, these are vertical. So when area, meaning different parts of the spine, first, it's indicated for lumbar spine. There's no Vertiflex currently released for the neck or the thoracic spine. It's only the lumbar spine because the shape wouldn't allow it to necessarily work in the other places. But you can put two of them in at a time. You could do more than that, but the insurance companies won't allow coverage for more than two at a time. So generally, we're putting one or two in at a time. It really depends on where your stenosis is. And you might have 5-level stenosis or 4-level stenosis. I see these people coming in with these multi-level stenoses all the time. So we'll ask you questions about, does it ever go in your leg? Does it go to the front of your leg, the back of your leg? Do you have numbness? And all these questions are designed to try to nail down which one of those 5 stenoses are most important so I can limit it down to 2 and hopefully still get the great result that I want. So yeah, you can do 2 at a time, but not more than 2 at a time based on coverages. I think I went over everything that's on that previous slide. Okay, so let me go over one more time what the procedure's like. Of course, it's FDA approved. There is a small incision. It's about 1 centimeter high on the exact center of your back. So when you have the procedure done, you'll be belly down on an x-ray table. Generally, you're sort of snoring on sedation, and we numb up the skin area and tell you where we're numbing. You might wake up for a second while that's going on because it pinches and burns when you get the local anesthetic. And then beyond that, you don't really feel a lot. You usually don't remember a lot. I have done this procedure without any sedation. So people were wide awake, especially people that have really bad lungs, and their doctor, pulmonologist, insists on them not getting much sedation. Frankly, the people don't feel the procedure very much at all because we can numb it up pretty darn good. But having said that, almost everybody wants sedation, so that's what we provide. And it's a fairly easy operation. When we go in there, we make that vertical incision, and there's a lot of wiggling around, making it perfect under x-ray guidance. You'll see x-ray cameras in the room when you're brought in the room. After we get the implant in and deploy the little fins, the little purple fins that you see on the picture there, then it's done. All we have to do is, wash it out and sew the skin shut. And there's really, it's a very small procedure. Like I said, it's 15 minutes per implant. So 30 minutes for 2. And I would guess that maybe I do, maybe 3/4 of them are 2 implants. And 1/4 is probably 1 implant, if I had to guess. You're in recovery for about an hour afterwards, just to, get your pain treated if you have any pain. Most people don't hurt much after this in recovery because they're still numb inside. If you are, we give you pain medicines and do whatever to make you comfortable. You generally get a pain pill prescription on your way home, sent in. Generally, antibiotics before and after, and maybe a prescription at home for the antibiotic pills to take that your doctor will give you to. People ask about recovery time, and before this was really a popular procedure when it was sort of in its infancy, we didn't really get the rules to recover a patient. And so we had to sort of, all over the country, we were making it up and being more cautious. A lot of the product literature says 6 weeks, no bend, lift, twist. But in our practice, and again, other places are different, but in our practice, I like to tell people for about a week to 10 days, you're going to have soreness in your back, like a bad back day. Maybe, maybe not. If you have any pain, be a little aggressive at taking your pain pills. It's okay. Make sure you take your antibiotic pills, but don't do anything exciting for about a week to 10 days. You know, be a little lazy. That means you're up and around. You're doing, you know, make yourself a sandwich, going from here to there. And we ask you not to drive for a week. But beyond that, the implant is in there and it's solid metal. And these don't come out and fall out or anything like that. They go in and they stay in. If you look at, can you point to with your, I don't think I can do it. Yeah, one segment higher. Right there, back to the right a little bit. See that notch that goes up in the bone above? That is a larger area than when you go more to the right. So the implant likes to stay put right there, and it won't work its way out because it's more narrow. So it is anatomically a perfect location for an implant because the anatomy keeps it where it's supposed to be. So what I said a little while ago was that the parent company, the Boston Scientific, engulfed to be able to get this procedure, did great with the original studies. They did 5-year studies. We call that level 1 research, which in medicine, if we have a device that works for 5 years, it's considered to be permanent for a lifetime. So I have had different manufacturer defects in every different device I've ever used, but there is an extremely low rate of problems with Vertiflex because it's such a simplistic design. So,
excuse me, Dr. B, we do have one more question coming through.
Sure.
It says, I have already had the mild procedure and I still have pain. Would this be the next step?
If she or he gets better with sitting, yes, definitely. Mild procedure is, and I'll bring up a model here. If you look at, this is like you're looking into the back of a person. This area right here, you can go in with a mild procedure and you can take out tissue here just in the center. Vertiflex is very different. Since it jacks open this space right here, it provides relief of stenosis from right all the way over to the left. So instead of just taking out central stenosis, the Vertiflex takes out stenosis from right all the way through the center, all the way to the other side. So it's not equivalent. Vertiflex is a product that satisfies a lot more pain states than mild will. Okay, so I hope that answers the question. We'll keep going. Please feel free to ask more questions.
I think it does. Thank you.
Good, thanks. Patient satisfaction scores, all these different things. You can look at it, and the thing that strikes a physician is 90% success rates at getting a success. Now, what you consider a success is 85% drop in opioids, 81% physical function improvement, leg pain. But what we want to see is we're helping people a whole lot 90% of the time. And that's what makes a doctor happy. The patients can break it down into, you know, what part of their function got better, if it helped their back or leg or things like that. But you can't predict those things ahead of time. You can predict that you're going to get a success 90% of the time with this procedure. And almost all of them get multiple things that they have as benefits. But the thing to hold your hat on is that 9 out of 10 on the far left-hand side. That 90% success rate's pretty striking in medicine. Most things aren't that high of a success rate in all of medicine, whether it's heart, lung, liver, kidneys. 90% is darn good, especially for such a simplistic procedure. Next slide, please. Boston Scientific just a few years ago bought pain.com as a website, and it's really pretty good. At Patient Education, I would definitely recommend it. We docs that do a lot of equipment that, you know, Boston uses give advice every once in a while, but overall it's a pretty darn good website that has details about more than one procedure. So I definitely tell people to look at it. They even put the identical information that we have in brochures that we hand to people on the website, so you can see it both places.